criteria, and also how you analyze the data. Do you have ways of making sure that you will be doing an analysis that is up to date with the rest of the science?
Well, I think we have ways to do that. Again, CDC's program is science-based, and we use the most sophisticated techniques and go through a publication process where we have peer reviews and get comments on what we've done. I mean, there are times we have done things and the peer reviewers point out, well, you should have done this or that, and you know, that's the nature of science. So you read the literature, you try to stay up with everything, and then you get corrected by your peers, and it's an evolutionary process.
You're talking about during the review process when you submit a manuscript, is that right?
Yes, yeah.
Gailen, then Eileen.
Beth, I'd like to add.
Gailen, Eleanor. Gailen, then Eleanor.
Beth, I'd like to add my appreciation to that Art mentioned as well, for your openness and your candor in what you say. And one of the things that I have found to be very important in patients, all patients who are ill, which certainly keeps the CFSME patient in the middle of this, is that when someone is ill, their mind doesn't work as well as when they're not as ill. Somebody with mental illnesses can have physical manifestations. Unfortunately, in our society, physicians, and as a physician, I can mea culpa for my profession, have far too many times when a patient comes in and sits down and tells the doctor that they're ill, has determined that they have a, quote, psychosomatic illness, unquote, which is code speak for you're crazy, get out of my office. And I think that the CFS population has suffered long enough in that mindset. And so you say very clearly and appropriately that your group will approach and will continue to approach the research and care for CSF in terms of recommendations from a science standpoint. I would encourage you and would like you to comment on this, that number one, it's not lost on me that it was put in a specific infectious branch to be investigated by CDC. There's been a lot of accusation, and I think not totally unjustified, that the CDC has thought too much that this was a mental illness in individuals, that it was not, quote, real, or that it was not something that is amenable to infectious disease type research. In my conversations with you, I don't think that you feel that way. I've talked to Mike. I don't think he does as well. But I think it's important for you to iterate that you don't think necessarily that everything related to this illness can be put down into a laboratory and dissected out to the point. These are people. These are human beings. And some of that supersedes that. And I do believe that you and Mike and others in the CDC are sensitive to this, and I think part of this is the publicity. And there's this dichotomy of science and medicine somehow, that doctors are sympathetic to patients and scientists are not. I don't think that's accurate, but I think that it's understandable why many people have those impressions. It's a very long introduction, but the specific question that I would ask you to address is that as your branch goes forward in investigating this illness, I'm assuming that you have clear intent to include all the aspects, the social aspects, the clinical aspects, which are admittedly less precise in terms of numbers that you can sit down and to get a p-value for and put into a paper.
Yes, we have every intention of doing that, and just let me say that I think there has never been any doubt in the CFS program at CDC that there is a biologic basis for this illness. And I think it is not code speak in our mind if we talk about a psychosomatic illness. It is a reflection of the mind-body connection. And I think that is one of the things our society does not do a good job of understanding. There is a mind-body connection. And when you start understanding how people respond to their illness and how their illness affects them, it is a circle. You need to understand all aspects of this. That does not stop us from looking for infectious causes, and infection affects people's behavior and their personality and how they cope. Infection is a kind of a stress. And so stress, again, is another word that's very poorly understood. But let me assure you that this illness requires a multidimensional approach. You cannot just look at one aspect or the other. And that is why the CDC program has become broad and made sure that we have experts that can address the various components of this illness, because, you know, we as virologists or as pathologists can only do one part of it. We need input of the people that understand behavior and all of the other stuff that goes along with it.
Eleanor, then Eileen, and then Lenny.
Well, I really just was going to ask, is your research data center in your...
Get to the mic, Eleanor, because I can barely hear you.
Is your research data center within your own purview, or is it part of the National Center for Health Statistics, because they have something very similar?
It is it is not a national center. It doesn't belong to our national center. It's an agency-wide program.
I was just wondering if there would be advantages to incorporating it into the National Center.
It is not our. It doesn't belong to us personally. No.
Eileen.
My question is that at this time where there's so much controversy over standardized testing, the way we collect data, store it, analyze it, and it's so important to standardize testing, it seems sort of an apparent contradiction that we are utilizing different definitions for study groups, which seems to be like cause convoluted, you know, conclusions, and it muddies the water. So there seems to be this dichotomy of, well, in one regard, we're standardizing everything, but then we're using different definitions. How can you reconcile that?
Yeah, I think that's a very good question, and it does sound confusing. I understand that. I think you need to understand that most papers will start out saying they used the 1994 case definition, and they don't explain how they used it. The one difference that we did was we explained how we used it in great detail. And I think that the 1994 case definition, and there was a meeting that a lot of people attended, that indicated there were a lot of ambiguities or a lot of different approaches that people could use to apply the 1994 case definition. And so what we did was come up with a very specific, I guess somewhat standardized instruments to measure each aspect of the 1994 case definition, and we spelled it out. Now, what we didn't do was get a lot of detailed explanation about how we came up with our cutoffs. We didn't provide that to the group, and that's what we need to do in the next paper, and then discuss, you know, should we have used this cutoff versus that cutoff. And when you start using instruments to measure various things, when I say instruments, a lot of them are questionnaires. They've been used in a number of different studies. Then you can start saying, wow, if I use this cutoff, you know, the population isn't the way that I would like it. You know, you could shift the cutoff one way or the other. And it will allow, in the long run, for people to have more reproducible ways of grouping people with their illnesses. Now, people and illnesses, you know, honestly try to defy classification. What I mean is there's a lot of fuzziness. And even in the same group of people, if you give the same questionnaires, you know, a month later, the illness changes, people change, and nothing is going to be absolutely reproducible. And we do have to understand that, which is why I'm saying we need as many different dimensionalities as we can get. So it's not so simple to say this person meets criteria, they're CFS. Clinically, it's a very different situation in that if you don't meet all aspects of the case definition on one day versus, the next time you come in, unless the illness is resolved, clinically they would be still managed as a CFS patient. So the main reason that we try to come up with a research case definition is, again, to try to assure that the findings are reproducible from one group to the other. And despite years of using the same case definition, a 1994 case definition, that hasn't been happening. And that's one of the things that has really blocked progress, in that one group finds one thing and the next group looks for it and doesn't find it. And I don't believe that it's poor science. I believe it's differences in the patients that we're not fully accounting for. And that is, if we can solve that problem, and that's where, having dialogues and measures, and people look at their patients and realize that, there's got to be something explaining this problem. And those differences could also impact response to therapy, and could become very good stratifiers for directing therapy as well. And that's what I hope will happen as we move forward.